Hi, everyone. I'm so excited to be here talking with you all about diabetic foot infections and skin and soft tissue infections. So why are we covering this topic? Well, skin and soft tissue infections are the most common infections seen in both the community and hospital settings. Additionally, diabetic foot infections are arguably the most prevalent infections amongst diabetic patients. So of interest, methicillin-resistant Staph aureus acquired in the community setting or community-acquired MRSA, commonly present in purulent SSTIs, is an organism of increasing concern, meaning that we're seeing more and more of these infections. So this handout will explain in detail several types of SSTIs, their associated causative organisms, and then finally the appropriate non-pharmacologic and antimicrobial related treatment regimens. So why are we covering this topic? Excuse me. So the to-do list for this would be make sure you read why we're covering the topic. You want to make sure that you review the below learning objectives. You want to read through the handout. You want to use the objectives to focus on the important concepts. And then you want to read over the PowerPoint slides and listen to the link, of which I will place right in here for you all to find. And then you want to submit the muddiest points of the discussion to the SSTIs and DFIs discussion page right there on Canvas, the one that Dr. F readily uses. I myself will also use that for you all. And if you have any additional questions, please feel free to put them there so that the rest of your cohorts can see it. Or of course, you all are definitely more than welcome to go ahead and just email me personally and ask me any questions that you may have. So by the end of this activity, if given a patient case, you all should be able to describe the causative factors contributing to different SSTIs and DFIs. You want to be able to identify common SSTIs and the associated causative organisms. You want to be able to explain the pathophysiology, the common pathogens, the risk factors, and categorize infection severity for SSTIs and DFIs. You want to determine the appropriate non-pharmacological treatment regimens for SSTIs and DFIs. You want to recommend appropriate antibiotics for empiric and then definitive treatment based upon the IDSA guidelines for the management of SSTIs and DFIs. Here I have the common abbreviations so that if it ever becomes too much, you all are like, okay, well, how do I continue to keep up with all of these different abbreviations that I'm seeing throughout the presentation or throughout the PowerPoint? Here they are right here, the most common ones that are utilized. So let's go ahead and talk and introduce this topic. So for the epidemiology, greater than 4 million patients visit the hospital every single year, and those patient visits are attributable to different SSTIs. There have been an increasing trend in the number of emergency room visits per year associated with SSTIs, and this upward trend in the severity of SSTIs is heavily attributable to an increase in the dissemination of community-acquired MRSA, which is a typical causative pathogen in severe SSTIs. So pathophysiology, the skin serves as a physical barrier, which prevents the invasion of organisms, thus functioning as a barrier between humans and then their environment. So in the event that the integrity of the skin is altered, meaning that you have a cut or you have some type of wound, then that creates an opportunity for an SSTI, or it creates the opportunity for those normal pathogens that are on our skin, so like strep, staph, to go ahead and seep through that open area and then wreak havoc or cause infection. So there are several mechanisms in which the skin is able to protect itself from this cause of infection. So relative dryness or being slightly acidic. So the skin has a normal pH of about 5.6. It has multiple layers, and then it constantly renews that top layer of the skin, which results in the shredding of keratinocytes and then different bacteria. It also has sebaceous secretions, which then hydrolyze to form fatty acids that prevent that growth of bacteria or fungi. And then we have a normal flora on our skin, just like with anything else, that prevents the growth of more pathogenic or bad organisms. So our skin does its job in working hard to protect us. It's when that integrity of the skin is compromised, when an individual is immunocompromised, that we see more in terms of infection with skin pathogens. So the main mechanism for the development of an SSTI is a disruption of normal host defenses by puncture or abrasion or underlying disease, as I previously explained to you all. And the nature and severity of disease depends on both the type of microorganism and then the site. meaning that if it's MRSA, which we know is really bad, so methicillin resistant, that can mean that the infection may present as being worse just due to that organism being such a bad organism. If it's MSSA or if it's strep, it may not necessarily be a terrible presentation in terms of the infection. If you're immunocompromised, and of course, an infection in that person is going to look a lot different than if someone that has a competent or working immune system, the way an infection looks there. So the following are risk factors or conditions that make the skin more susceptible to infection. So damage of that corneal layer, allowing for bacteria to go ahead and penetrate through the skin. High concentrations of bacteria in certain areas. Excessive moisture of the skin, so that changes the pH. Inadequate blood supply, meaning that you don't have oxygen, therefore you can go ahead and have infection. And then the available bacteria nutrients. So bacteria need things just like humans need things to survive. So in the event that the bacteria have that, then you can go ahead and see an increase in infection. So I usually do a stop before we go ahead and we discuss specific steps of SSTIs or infections so we can regroup and make sure that we're understanding what we're about to step into. So in this stop, I want you all to think about the fact that there are several factors included in working up an SSTI. So we're going to go through a stepwise approach that includes key factors to consider when devising a full plan to manage the infection. Keep these steps in mind while going through these various SSTIs. So first, you want to identify the infection source as an SSTI, meaning that we know, and you guys have talked with Dr. F about different sources of infection, different ways that infection or bacteria or different pathogens can enter the human body. So you want to make sure that the source of how this patient presents is actually an SSTI, right? You want to list the likely organisms related to that SSTI. So you want to think, okay, I know for a fact this is an SSTI. What are the likely organisms that are included or causative of this type of presentation? Let me think about that, because then you want to go assess the potential for multi-drug resistance, meaning I know these organisms. I know MRSA is typically resistant. So now I'm thinking about what can I use in terms of antibiotic treatment, because you've already ruled out a number of drugs at that point once you determine that it is indeed SSTI and you've determined that site of the infection or the type of bacteria that caused that infection. Then you want to determine the extent and then the severity of that SSTI to determine the way you want to treat it. So now you know what SSTI is causative, you know what type of pathogens cause this type of SSTI, but then you want to take into account, is this mild, moderate, or severe? Can I get away with doing PO treatment? Do I need to go ahead and do IV? Then you want to determine if the source control can be obtained physically, meaning can we get rid of this infection if we just remove that source? If we debride, and sometimes you may still have to use antibiotic treatment, but you want to make sure that the antibiotic treatment will be able to penetrate through in the event that debridement is necessary, right? We know what So we want to choose the empiric therapy based on the workup of steps 2 through 3. And then if and when cultures return, then we want to make sure we tailor our antimicrobial therapy to the specific organism that is causative. So we want to just keep these steps in mind as we work through these different types of SSTIs. So with going through we're going to start from the bottom up. So when we think about definitions or SSTIs, you can have one being folliculitis. So folliculitis is common. It's inflammation of the hair follicle, typically caused by physical injury, chemical irritation, or infection. You can also have a furuncle, which is commonly referred to as a boil. So it's like a collection, or it's that scale up of folliculitis. It presents as a walled off mass or purulent material arising from a hair follicle. The infection typically extends beyond the hair follicle and around the hair shaft, involving subcutaneous tissue. And then a step up from that furuncle is a carbuncle. So it's a lesion that's adjacent to furuncle coalescence, or meaning a collection of furuncles, to become a larger mass to form a huge single inflamed area. And then you can have a cutaneous abscess, which is then a scale up from that carbuncle, or collections of pus within the dermis or deeper skin tissues. So commonly the pathogens that are associated with these types of SSTIs our staph. We know that staph is a skin pathogen, right? So it's very easy for you to maybe have an ingrown hair. It's very easy for you to scrape your skin, and then the staph go ahead, get into that site and cause infection. So majorly Staph aureus, and it can be MSSA, or it can be community acquired, which is what we see a lot of times in terms of skin and soft tissues infections. It can be community acquired MRSA. So these types of SSTIs are considered purulent, meaning that they have pus that drain out of them. And a classic characteristic of an SSTI caused by Staph aureus is purulence, which is the most causative organism within the presentation of these infections, as previously stated. So outbreaks of furunculitis caused by Staph aureus, including community-acquired MRSA, have been reported in settings of close contacts. So when you think about furuncles, carbuncles, potentially that abscess, a lot of times it can be passed from person to person, where that bacteria can go from person to person when you have large groups that are together. So in families and in prisons, you can see that. And then a skin injury or some type of contact sport. So it typically happens when there's some type of opening to the skin, and then the bacteria has a place to go. So folliculitis, it can be small pruritic erythematous papule localized to the hair follicle, can involve into pustules or rupture. And then common location is areas subject to friction or perspiration or sweating. So causative organisms can include Staph aureus. In rare cases, it can be Pseudomonas. And that can be in cases in which there are swimming pools, hot tubs, things like that. We can also have a furuncle. So it starts as a small, firm, red, tender nodule that becomes painful and pustular. This can commonly be on the face, neck, axilla, or the buttocks area. Once again, causative organisms can be Staph aureus and then other Staphylococcus species. We can also have carbuncles, which are commonly just a group of furuncles that come together and form a larger area of infection. These commonly form on the back or on the neck. Once again, Staph aureus being our prominent organism here. You can also have a cutaneous abscess, painful, tender nodules. And then once again, common location can be more around abrasions or compromised skin. And Staph aureus is a common causative organism here. Abscesses can oftentimes be, and as we move forward, and I'm sure that Dr. have talked about this in bone and joint infections, abscesses can often be polymicrobial because now you're allowing for bacteria to be able to just congregate in one space. And sometimes you can get the joining of bacteria that's not necessarily heterogeneous or homogeneous or explicitly the same. So sometimes abscesses can include different types of organisms. And because it is on the skin, it can typically include different types of skin organisms that are able to just go and congregate at that one site, that one area. So for laboratory testing, these types of SSTIs are typically diagnosed and treated purely from presentation. However, in the case of carbuncles, which can lead to abscess development, and abscesses that can be polymicrobial, the following is performed at times. So really for carbuncles, as we scale up in the way that these present, we will consider doing a gram stain. We will consider doing a culture of the pus, just so we can better tailor our treatment therapies. So the goal of therapy is a resolution with no or minimal scarring and to prevent reoccurrence of ththese infections. Additionally, we want to minimize the risk of developing endocarditis or osteomyelitis, meaning introducing those skin pathogens to us and having them present some type of systemic formation. So we want to keep this as close to being a skin infection as we possibly can. So the major disposing factor in recurrent infection is the presence of Staph aureus in our nares, meaning that if we have Staph aureus in our nares, it's easier for us to continue to develop skin infections because that means that your body continues to have access to this really bad bug. So that's why oftentimes we will talk about decolonizing the nares so that we can get rid of the presence of staph so that it's less of an incidence that people are able to have staph available when they have an abrasion or when they are immunocompromised to go ahead and cause these skin infections. And we'll talk more about decolonization and all that jazz. And then if you guys come on to rotation with myself and Dr. Kenny, we do a lot in terms of decolonization and walking through Staph aureus presentations. So for non-pharmacological therapy, the first line recommendation for management is non-pharmacological therapy. So the common recommendation for folliculitis, you typically don't need antimicrobial therapy. They oftentimes resolve spontaneously. Folliculitis can often look like an ingrown hair, and I know that I've had them. I'm sure that others of you all have had folliculitis or ingrown hairs, and they typically resolve spontaneously. Furuncles can often rupture on their own or following treatment, and you can just use a warm compress for those. For carbuncles and cutaneous abscesses, incision and draining is our gold standard because it'll be important for you to go ahead to get that bacteria out of the area. It depends on how the patient presents in terms of using systemic antibiotics and things of that sort. I know, and knock on wood, when I gave this lecture last year, I talked through SSTIs, and sure enough, my husband had an infected grown hair that turned into an abscess. So it was right there underneath his arm, underneath his skin. So he actually did the incision and drainage, and then he went ahead and took antibiotics right after he did the incision and drainage. So topical therapy may be used to control the spread of folliculitis, but it is often not required. Systemic antibiotics are usually unnecessary unless the patient presents with some type of systemic presentation. So that means that the patient has a temperature greater than 38 degrees Celsius, if the patient is tachycardic, if the patient is tachypenic, if the patient has an increase in white blood cells, then you want to go ahead there and you want to start them on some type of systemic antibiotic. So what I mean by that is that doesn't necessarily need to be IV, but you want to make sure that you use more than that topical therapy, right? So if you want to use antibiotics that will be bioavailable, that will distribute via our ADME system, right? So the choice of antimicrobial agents should include those that have coverage against Staph aureus. So when we are treating for these types of infections, in the event that you don't have any indication that the patient may have some type of MRSA infection, which we will go through, then it's fine to use agents that cover solely for MSSA to not involve those that cover for MRSA. So MRSA coverage is recommended for severe infections. This means that the selected agent must provide coverage against both MSSA and MRSA. Agents that cover for MRSA always cover for MSSA. So this means that agents cover for Staph aureus. We know that MSSA is Staph aureus, right? So MRSA means that it's methicillin resistant Staph aureus. So if it covers for methicillin resistant Staph aureus, it also has to cover for MSSA, right? So the thing is that agents that cover for MSSA, however, do not always offer the extra scale and coverage for MSSA. For MRSA. Severe infections, however, severe infections requiring MRSA coverage are classified, are needed in those infections that present with at least one of the following characteristics that are listed. So for those patients that have failed antibiotic therapy and those patients that have greater than or equal to 2 of the 4 criteria for SIRS plus hypotension, in the event that you have an immunocompromised patient, then you want to make sure that you have an agent that covers for MRSA. That means that they have a severe infection, meaning you want to scale up on their therapy. We'll go through the algorithm and I'll better explain that so you all are explicitly clear on that. So here we just have a listing of the pharmacotherapy agents that are used in the empiric treatment of purulent infections. So for mild infection, you can use clindamycin, erythromycin, mupirocin, and those are our topical agents. You can also use benzoyl peroxide. For our moderate infections, we are going to think about our oral agents that cover for MSSA for a moderate presentation, because if it's not, that means that it's not severe, meaning that we aren't necessarily in that place where we're saying, okay, we need to explicitly use MRSA agent. So if we're solely just worried about MSSA, you can use NOD if you have staph, right? So our anti-staphylococcal beta-lactam that is orally available. We can use hydroxycillin for a moderate infection. No reason to use IV therapy. We can use cephalexin, also a PO option. We can, if we want to go ahead and cover for community acquired MRSA, meaning that they don't necessarily need IV therapy, but they're meeting this criteria that we talked about in terms of needing to scale up for MRSA coverage. We can use Bactrim, we can use clindamycin, we can use our tetracyclines, or we can lean into that doxycycline, right, or that minocycline. And then when we go into that severe infection, meaning they are needing IV therapy, but we don't necessarily think that they need to be covered in terms of MRSA, we can use nafcillin, oxacillin. We can use cefazolin, which is our scale up from the dicloxacillin and the cephalexin, right? We can use, if we know that we need MRSA coverage. And typically, if you have someone with a severe infection, you are just inherently going to cover them for MRSA, because if they're presenting in a severe fashion, then you know that this infection is bad. So we'll typically go ahead and start right out with those MRSA agents. We know vancomycin is our gold standard, daptomycin, linezolid, tadalafil. We also have ceftaroline there, but typically we'll start with vancomycin. In the event that we start to get results back, meaning from our cultures and all that jazz, that tell us that we can narrow therapy, then we'll start looking, and the patient still requires IV therapy, then we'll start looking to these MSSA agents. So for follow-up, definitive therapy, if coaches are obtained, you want to make sure that you tailor definitive therapy to be that most narrow agent. Meaning if you started with vancomycin, you get the results back, you know that it's MEK negative, meaning that MRSA is not there, then you want to say, okay, let's scale it back. Let's go to the cefazolin. Let's go to the nafcillin, oxacillin. We don't need to keep this big agent on. If the culture and susceptibility results reveal the organism is susceptible to dicloxacillin, then do not continue an agent that provides MRSA coverage. So vice versa, if you ended up using a PO agent and the patient and you ended up getting results back, then of course you can scale back. Oftentimes though, if you start a patient on doxycycline, you'll just continue them for that course of therapy. It depends on how the patient presents, whether they're in a hospital when you get cultures back or things of that sort. So an additional life hack, if the patient has a penicillin allergy, you can use Bactrim for strep pyogenes or clindamycin for strep pyogenes and Staph aureus coverage. I know oftentimes, and I know you all have talked about beta hemolytic strep, and coverage with Dr. F, but in the event that you get a patient, they have a penicillin allergy, you still want to treat strep pyogenes, you still want to treat Staph aureus, you can go ahead and you can use Bactrim or clindamycin. So for mild and moderate infections that can be treated with oral agents, MSSA, if we are treating for MSSA, meaning that we don't necessarily have any indication for MRSA infection presence, then we can go ahead and use our anti-staphylococcal PO beta-lactams. So those being dicloxacillin or cephalexin. If it is MRSA, then we can go ahead and use Bactrim or we can use clindamycin. Severe infections will require treatment with IV therapy to ensure that that pathogen is eliminated. If an infection is severe, that means that patient needs 100% bioavailability there to get rid of that pathogen. So you want to make sure that you go ahead and you use that IV therapy based upon severe presentations. So severe infections will require treatment with IV therapy. As we stated, the IV therapy may be for the complete duration that the patient is treated for the infection. So if MSSA, you may use cefazolin or nafcillin for the entire time that you're treating based upon whether that patient gets better or not. Clindamycin is also an option because it's easy to go ahead and switch from IV to PO. However, you do have that increased risk of C. diff. So we're always kind of mindful of how we use clindamycin in these instances. In the event that this patient has an MRSA infection, then you'll go ahead and you'll use vancomycin as that drug of choice. And then other anti-MRSA IV options are available based on that patient presentation, meaning that they have vancomycin resistance, meaning that their MIC or when tested and you get the MIC results, so that minimal inhibitory concentration required to eliminate the continued growth of that organism, say that it's higher than that break point or where the data says that patients actually perform well, then you'll say, okay, I don't want to use vancomycin because the patient may not perform well on this. Then you can consider daptomycin, that works a bit different. You can consider linezolid, but we'll go more into detail about resistance and how we navigate that when we have the class on Monday. So life hack, the patient may go ahead and improve clinically and be a candidate for PO oral therapy. In this case, the patient may be transitioned to a PO active agent. It is important that the most narrow agent for the isolated pathogen be given. So the duration of therapy will be about 5 to 10 days total. So I have a treatment algorithm here, and I'll walk you all through. So say you have a purulent SSTI, which we know that these SSTIs fall in that purulent meaning they create pus. So you have SSTIs that present with pus versus those that do not. These are those that do. And when you think about an ingrown hair, usually has pus coming out of the top of it, right? So included in those purulent SSTIs are furuncles, carbuncles, and abscesses. So in the event that the presentation is mild, then you can just go ahead and do I&D. In the event that is moderate, and this includes systemic signs of infection as described, then you can do I&D. You also may want to pull a culture and sensitivity analyses in the event that is carbuncles or abscesses, as we talked about. For empiric therapy, we can go ahead and do clindamycin, we can do Bactrim, we can do doxycycline, because if that patient is presenting moderately, then we likely want to start with MRSA therapy in the event that that is the case, based upon what you get in terms, if you do culture and sensitivity, you can then scale down. So for definitive therapy, we can go ahead and you can stay with the Bactrim if we know that it is MSSA, meaning that we did get some type of culture and sensitivity result. You can do dicloxacillin, you can do cephalexin. In the event that a patient has severe presentation, meaning that they meet that SIRS criteria or they're immunocompromised, then we'll still do that I&D, because the best thing that you can have for these SSTIs is some type of source control. And then you want to go ahead and give empiric therapy. So if it's a severe presentation, we know we want to do that IV therapy. We want to start with those IV MRSA active agents. And then based upon cultures or results, based upon what you know in terms of the specific or definitive organism, you can go ahead and tailor the therapy. We then have we have additional infections. We have impetigo, cellulitis, erysipelas, and lymphangitis. So impetigo is our superficial skin lesions that typically present on the face. We have cellulitis, which is an infection of the dermis and then subcutaneous tissue. You can have erysipelas or St. Anthony's fire, which is a distinct form of cellulitis involving more superficial layers of the skin and the cutaneous lymphatics. And then you can have lymphangitis, which is inflammation, including the subcutaneous lymphatic channels. So all of these infections, with the exception of impetigo, fall underneath that cellulitis umbrella, meaning it's inflammation of just the cells in various areas, or the lymph nodes in various areas. So etiology, patients will often present with the following premeditating factors. So they'll have wound from trauma, they'll have an abrasion, they'll have an ulcer, they would have had surgery, IV drug use, meaning that they have some type of opening to their skin and bacteria is able to go ahead and congregate and then wreak havoc. So organisms that cause these infections are typically related to the specific region. So lower extremity infections can be caused by gram-negative organisms that are present in the GI tract. So we'll think of just GI organisms, or gravitation, meaning that the organisms can then go ahead and seep into the skin. So other host factors, previous antibiotic exposure, immunocompromise, different types of exposure. So if you're in the water, you have some type of wound, you have some type of trauma, you can get a Pseudomonas infection, because we know that Pseudomonas are water organisms, right? So important organisms to think about here, especially for cellulitis, are Streptococcus. Those are other organisms that are present here on the skin, but those are the ones that are typically most virulent in what we see in terms of cellulitis presentation. So less frequently, we can have Staph aureus there that causes infection, but MRSA is becoming more of a presentation in these infections. organisms that may be present due to special circumstances. So animal bites, salt water, freshwater injuries, suppression. So sometimes you can see gram negatives in that instance. So, and then patients with diabetes or vascular injury are more prone to having polymicrobial, or meaning several organisms that can be causing that cellulitis because they are immunocompromised. They often have other organisms that are around to play that can seep into those open areas and then wreak havoc. So clinical presentation, the infections can be locally. They can be, symptoms can include the affected area feels warm, pain, tender to the touch. We have various signs. So redness, edema, warm, blistering. We can also have a general presentation that presents with fevers, chills, malaise. And then you can see leukocytosis, tachycardia, hypotension. So we know that the general presentation is a little bit more concerning than that local presentation. So for laboratory, we can go ahead and grab gram stains, cultures, biopsies, swabs of the cutaneous aspirates. And however, it is not routinely recommended, but you can do that if need be. There may be instances, but clinically, we probably would not grab cultures from these sites of infection. So culture results may be negative despite obtaining aspirate samples. Alternatively, the results may be positive in polymicrobial due to contaminants that are present. So culture results must be interpreted with caution in these non-purulent infections. So imaging may be used to identify abscesses formations, the presence of gas in the soft tissues, or bone involvement. So in the event that you treated the patient for the presentation of cellulitis is pretty signature. So when we see it, we're pretty much aware of what it looks like and how it presents. However, if you're treating this patient and the patient is not getting better, then oftentimes you will go ahead, you may grab a culture, you may aspirate the area to go ahead and pull out some type of culture or the specific organism causing the infection. And then, like I said, if they're not getting better, you're seeing some type of necrosis, meaning that the area may be getting dark, then you may go ahead and do some imaging just to make sure the patient doesn't have any type of bone involvement or things of that sort. So blood cultures, bacteremia only occurs in about 30% of cases, and IDSA recommends against blood cultures unless the patient presents with severe systemic features, as previously described. So like PACT, in severe infections, you want to continue to monitor the CBC or the complete blood count just to make sure that there are signs of improvement. So our goals of therapy are to rapidly eradicate the infection and prevent any further complications. We want to minimize the inappropriate use of broad spectrum antibiotics always. Antimicrobial stewardship to be at the forefront of our minds. We want to minimize toxicities and then the cost of therapy. So as ID trained pharmacists, right? You guys we're welcoming you into our ID training world. The one thing that's very important is to go ahead and we want to make sure we're practicing good stewardship here. So pharmacotherapy considerations, therapy should be targeted against strep pyogenes because strep pyogenes is the more likely causative organism in these infections. So in any type of cellulitis presentation, we are going to be majorly worried about strep pyogenes. Strep pyogenes. When you guys think about cellulitis presentations, when you think about erysipelas, when you think about general cellulitis, when you think about lymphangitis, when you see anything along those lines, you want to immediately think to yourself impetigo. You want to immediately think to yourself strep pyogenes. So patients can be treated with oral therapy in the event that there is no systemic involvement. Typical therapy can include benzoyl peroxide, mupirocin, and it may be used to control that spread of the impetigo. So systemic antibiotics are used per that same algorithm that we utilized in the previously described infection. And then for severe infections, of course, they're classified per that same classification that we used for the previous description of the purulent infections. So there is potentially opportunity for an adjunct of anti-inflammatory agents. So if that is the case, you can consider the use of NSAIDs or ibuprofen. You can consider the use of corticosteroids. I have the recommended dosings listed here in the handout for you all in the event that you want to go ahead and read there. Life hack or just a bit of consideration. Corticosteroid use is a very controversial topic in most things, and skin infections is not much different. However, they can be considered if that benefit outweighs that risk, meaning that you have a patient, they come, you treated them with the antibiotics, their leg still remains to be inflamed, and it's painful for that patient. You may consider using methylprednisone or prednisone or a solumedrol pack for a short time period for that patient to allow for that inflammation to go down. So the treatment for impetigo, typically we'll use a topical treatment. You'll rub it right there into that area. You can use mupirocin, and we use the mupirocin for 7 days. Mupirocin is strep pyogenes targeted, right? It has activity there, so we can go ahead and use that. In the event that we want to use some type of systemic drug or PO medication, you can go ahead and use strep pyogenes active agents. So we can use penicillin VK, we can use dicloxacillin, cephalexin, clindamycin, once again, 7 days. To treat the other presentations of strep pyogenes mediated infections, erysipelas, cellulitis, and lymphangitis, we can go ahead and use just the narrow coverage. For streptococcus, the most narrow agent for strep pyogenes or streptococcal infections is penicillin. We'll go into more detail about this in the lecture, but do not ever forget, if you can count on one test question in any area of your life for the rest of your life as a pharmacist, penicillin is the most narrow agent for streptococcus. So for orally, we can use these agents that have activity against streptococcus. In the event that you want to cover for MRSA, then you can use the following agents as previously described. And if coverage for both, clindamycin, Bactrim, linezolid, tadalafil. For intravenous, you can scale up with therapy. I won't go ahead and read this. This will give you all an excuse to make sure that you go through the handout before the IRAT, which I truly recommend, but it lists all of the treatment regimens there. So just some clinical pearls for you all in choosing an empiric therapy for the above infections. Typically, the agents that cover for MRSA also provide activity against strep pyogenes, with the exception of doxycycline. Doxycycline does not have reliable coverage against strep pyogenes. So remember that doxycycline, while it covers for MRSA, does not have reliable coverage against strep pyogenes. Vancomycin is that preferred option when empiric IV coverage is needed for gram-positive organisms. Fluoroquinolone therapy is not recommended for uncomplicated outpatient cellulitis therapy due to its very broad spectrum of activity, and then also the MRSA nature in which infections can present. So you don't want to use fluoroquinolones because they do not have MRSA activity. In patients that are high risk for polymicrobial infections, that those being the patients that are immunocompromised, have had recent occurring hospitalizations, and present with severe cellulitis infections, therapy with vancomycin plus piperacillin tazobactam, or some type of anti-pseudomonal carbapenem is the recommended empiric regimen. So if you have a patient and you believe that they are at high risk for polymicrobial infections, meaning you have a patient, they are immunocompromised, you have a patient that's been recently hospitalized, you have a patient that's in the ICU, and they present to you and they have a very severe infection, meaning that you can visibly see that their leg area is inflamed. It's clear that they have poor systemic prognosis, meaning that the area is inflamed, their temperature is high, their heart rate is high, they are hypotensive, then you want to go ahead and you want to use vancomycin because you want to make sure that you're covering for MRSA. We know MRSA can be that really bad bug that may be present in a skin infection. You're inherently covering against MSSA. You're inherently covering against strep pyogenes with the use of that vancomycin. We know vancomycin is going to be our power block for our gram-positive organisms. But then you also want to use piptazo because if it's polymicrobial, right, we know that you can see gram-negatives. So we want to make sure we're offering good coverage for that, right, empirically. So for follow-up definitive therapy, if cultures are obtained, tailor definitive therapy to culture results. For strep pyogenes, you want to use penicillin. Penicillin is the most narrow therapy. And then for MSSA or MRSA, you want to refer to the above treatment regimens as previously described. Duration of therapy for uncomplicated 5 to 10 days. 5 days has been shown to be as effective. So we know that we want to consider the longer durations of therapy, so 7 to 14, in the event that the infection does not improve. So if you have cellulitis, erysipelas, lymphangitis, if it's mild, meaning no purulence, no pus there, you want to use a PO antibiotic with coverage against strep pyogenes as listed. So what's our most narrow agent? Penicillin, right? So we can consider that. If we want to treat more broadly because we're just not sure, but we know that we don't necessarily need to scale up, you can consider dicloxacillin, you can consider cephalexin, those agents, Bactrim, right? In the event that the infection is moderate, purulence is there. So now we are definitely suspicious for community-acquired MRSA because we know MRSA can be indicative of purulence, or Staph aureus can be indicative of purulence. So we want to make sure that we are treating for agents that cover for both MSSA, MRSA, and strep pyogenes. And then in the event that they have a severe infection, we want to make sure that we do that surgical debridement. We want to tend to that area of the cellulitis, but then we also want to give them empiric therapy. So we'll give them vancomycin and piptazo because we want to make sure we're covering for all potentially causative organisms. We'll do cultures, we'll grab susceptibilities, and then we'll go ahead and we'll tailor based upon what we get in terms of the culture and susceptibilities. We'll tailor our therapy based upon that. So now we have reached the end of the road and we are going to talk about diabetic foot infections. And if you all have made it through SSTIs, I have firm faith that you will be able to go ahead and make it through these diabetic foot infections. So there are 3 major types of diabetic foot infections. You can have deep abscesses, which then involve the central plantar space or the arch, and are caused by minor penetration traumas or extensive infection of the nail or web space of the toes, which is oftentimes if someone has diabetes, you will check their feet. So you can have cellulitis of the dorsum, which arises from infection in the toes that are related to routine care of the nails, nail beds, and calluses of the toes. And then you can have the male preference ulcers, always mess that word up, or chronic ulcers of the sole of that foot, associated with the neuropathic changes, because we know that diabetes can look like a decline in blood flow, or it can look like so that decline in blood flow can cause the formation of ulcers, or potentially individuals can step on things because they do have the neuropathy. They can't feel if they step on if they have some type of injury there. So 3 key factors that impact development of DFI include neuropathy, ischemia, and immunological defects. So the inability to feel the feet may lead to constant pressure on that foot, leading to the compromise of the tissue, as well as the unawareness of minor injuries and or ulcerations. So reduced vascular flow can lead to ischemia, which means death of those tissues, and that reduced supply of nutrients needed to maintain healthy tissues. And then also you can have an impaired immune system from uncontrolled diabetes, which once again increases that risk for infection. So it's really 3 factors there that contribute to that: neuropathy, death, then immunological defects from having that impaired immune system with diabetes. You know that diabetes is immunocompromising. So you have this classification of diabetic foot infections. I won't go ahead and read all of these through. I will let you guys do that just because it is wordy. But in the event that you all need clarification, we will discuss this in Monday's lecture. So important organisms to consider. In mild cases, MRSA are present in about 10 to 30% of cases. Streptococci are the most common pathogens, and gram-negative bacilli and anaerobes can also occur in about half of cases. So chronic foot ischemia or anaerobes will be most commonly present. So if the patient has decreased or chronic decreased blood flow to their feet, then you can bet your money that an anaerobe is probably causative of an infection there. For severe cases, Pseudomonas will be most commonly present. However, severe cases are often polymicrobial, meaning that this person has likely stepped on something, allow for some type of access to their foot, and then a ton of bacteria have gone ahead and infiltrated the foot through that site. So laboratory testing, cultures and susceptibility of the deep wound cultures. So at the base of the wound or bone cultures will be grabbed, especially in the event that it turns into a osteomyelitis type of presentation. So due to the rarity of cultures obtained from the base of the wound, it is often hard to identify those causative pathogens. Superficial stab wounds are not sufficient, so cultures must be collected via biopsies, or tissue scraping, or needle aspiration of that fluid. And then if concerned for osteomyelitis, bone cultures definitely be obtained. Typically, blood cultures are drawn in severe infections just to determine that particular source of the infection. So for lab values that we want to continue to monitor, we want to assess the white blood cells often. And that is because the presentation of diabetic foot infections is typically that in which you have a very high white blood cell count. So you want to be able to trend that and to see if it's improving. You also want to look at inflammatory markers. So inflammatory markers are our body's way of showing us that infection is present, but we know we don't rely solely on CRP and ESR to navigate or to diagnose these infections. So diagnoses of DFIs are based on the presence of at least two classic signs of infection. So that being redness, warmth, tenderness, or pain, or purulent secretions. So for non-pharmacological therapy, we will do a proper wound care. So you want to change the site of where that infection may be, surgical debridement for those moderate to severe infections, especially those with necrotic tissue, and then bed rest and leg elevation to control the edema that may come with the infection. We know inflammation, you have an increase in fluid. So you will want to make sure you tend to that site when you're giving the patient antibiotics. You want to make sure that we want to make sure we debride and take away that dead tissue so you don't allow for the white blood cell count to continue to increase. We want to make sure we increase the leveling of their foot as that fluid may go there. And then we want to maintain that glycemic control because we don't want them to remain immunocompromised with their diabetes. We don't want them to have another diabetic infection, right? We want them to be able to heal. So for pharmacotherapy management, for mild to moderate infections with no previous antibiotic use, using an agent with MSSA and streptococcus coverage is sufficient. So for mild to moderate, if they have not had any type of antibiotics and we aren't worried about multi-drug resistant, you can just focus on these typical skin pathogens because we know if it isn't presenting as severe, then it's unlikely that you have an anaerobe or MRSA present there, or a gram-negative one. So broad spectrum antibiotics that cover gram-positives, gram-negatives, and anaerobic pathogens may be necessary for moderate to severe infections, and combination therapy may be utilized. So this is as you increase in severity, as they have that service presentation, then you may want to go ahead and scale up there. So risk factors for MRSA and Pseudomonas should be assessed in moderate to severe infections. MRSA risk factors include the previous history of MRSA infection or MRSA colonization, local prevalence, meaning in that area, do they have MRSA rates greater than 30 to 50%? And if that patient is not improving on current non-MRSA covering therapy. And then for Pseudomonas risk factors, warm climate, soaking feet in the water. If the patient is not improving on current non-Pseudomonal therapy, then you know that they likely have Pseudomonas infection, meaning if you're giving that patient ceftriaxone, we know ceftriaxone does not cover for Pseudomonas, then maybe you want to scale up to a piperacillin, tazobactam, or a zosyn that does cover for Pseudomonas. Anaerobic coverage should be employed in ischemic infections. We know that anaerobes mean that the bacteria does not need oxygen to grow. So if you see necrotic tissue, meaning that there's no oxygen flow there, then you want to go ahead and you want to do anaerobic coverage. Route of therapy should be selected based on the severity of the infection. And intravenous therapy is recommended for severe infections and then moderate infections if chronically infected, if it is a chronically infected extensive region. So oral therapy can be used in most mild and moderate infections if it does not include that huge expansive area as previously described. In transitioning from IV therapy, to PO therapy is done based upon just that improvement of clinical response. So for mild infection, you would typically use these therapies that cover for MSSA and streptococcus, so as previously described, dicloxacillin, cephalexin, clindamycin, levofloxacin, amoxicillin clavulanate for MSSA. If we want to scale up and cover for MRSA, MSSA, and strep, then we can do Bactrim, we can do clindamycin. We know doxycycline does not cover for strep. However, if we're mainly worried about MSSA and the MRSA, then we can go ahead and defer there to the doxycycline. For severe, for moderate infections, if a PO agent is utilized, you want to refer to that list above. However, if the patient is requiring IV therapy, then we will scale up and give these therapies that are listed here. So this is where you bring in that moxifloxacin. We know that moxifloxacin is our tetracycline that covers for, we know that moxifloxacin is our fluoroquinolone. I'm looking at tigecycline as our tetracycline, but we know that moxifloxacin is our fluoroquinolone that covers for anaerobes, right? It does not cover for Pseudomonas the way that our other fluoroquinolones do. It covers for anaerobes. Remember that because we'll focus on that. It is our most narrow fluoroquinolone. And then we have tigecycline, which is our tetracycline that has good anaerobic coverage. So that's why in moderate infections where anaerobes can be present, we will see a scale up here of those therapies that include anaerobic coverage. And then for severe infections, we want to use vancomycin in combination with an anti-pseudomonal agent. Then you can use vancomycin in combination with a cephalosporin. If you use vancomycin in combination with the anti-pseudomonal cephalosporin, or if you use vancomycin in combination with the monobactam, we know that we are not going to be getting anaerobic coverage right. So we want to make sure that we tack on that metronidazole. If you have a severe infection, you want to be covering for every potential organism that can be experienced here. We say you can have gram-positive. We say you can have gram-negative. We say you can have anaerobic because the foot is open and a ton of bacteria can go to that open area. And we know that you have a decline in oxygen, so you can have anaerobic or bacteria that don't need oxygen that also come there. So you want to cover for that broad spectrum. You can use vancomycin plus piptazo or carbapenem. Those have coverage against gram-negatives. Those have coverage against anaerobes. You have vancomycin, which is really maximizing your gram-positive coverage. You have methaquota. However, if you have a severe infection, if you want to use vancomycin plus an anti-pseudomonal or a drug with pseudomonal coverage that is not of the ones that we previously mentioned, you want to make sure you tack on a drug that can cover for anaerobes. We know metronidazole has our most narrow anaerobe spectrum. spectrum. So you can use vancomycin plus those agents that do not cover for anaerobes but have gram-negative coverage, and then you can use metronidazole. So you can go between either using 2-drug regimen or you can use a 3. Remember this. This will guide you through, honestly, the remainder of ID because this will continue to come up. So for patient follow-up, duration of therapy for a mild infection, about 1 to 2 weeks. For a moderate to severe infection, you'll treat for about 2 to 3 weeks. Therapy may be extended up to 4 weeks, but this is if it's slow improvement of that wound. So that's why you want to make sure that you're going ahead and you're repacking that wound. You're doing proper wound care. You want to make sure you have proper glycemic control. You want to make sure you're keeping this patient's foot propped up. You want to do whatever you can to decrease the amount of time that they have this infection. So patient education and prevention. So we also want to make sure that we are educating them on proper foot control, on proper diabetes control, therapeutic footwear, appropriate vascularization, annual foot exam, weekly personal foot checks. We just want to make sure that we're keeping this in mind. So that is SSTIs and diabetic foot infections. I will proofread this handout and it will be posted for you all by the time that this video is. So thank you so much, and I will see you on Monday.